Hi, this is my cumulative skills presentation. My scenario is based off of Francis Christensen. Scenario as follows. I received a client who is admitted for dehydration, weakness, electrolyte imbalances secondary to post-chemotherapy side effects. The client has a right upper arm pick. The IV of 0.9 normal saline is running at 100 ml per hour. I've noticed that the central line dressing is due to be changed today, and the client is rating their abdominal pain currently at a 9 on a 0 to 10 scale, and we are scheduled to go to a CT in a little bit. So right away I plan on starting looking at my doctor's orders. I want to start my potassium piggyback that has been ordered. I also noticed that my patient is in pain, so I'm going to give him a morphine IV push. And then that central line change I'm going to do after I've administered the medications and got my patient both stable and comfortable. So I've gathered my supplies for this procedure, or these procedures. I have my secondary tubing and my potassium chloride secondary bag. I also have my change kit for my central line dressing, and I have my flushes, which I've made sure the air bubbles are out of already, and my morphine, as well as my necessary syringe for the patient room. I'm now going to enter the patient room to provide patient care. So I'll knock on the door. I'll wash my hands. Hello, Francis, my name is Bree. I am your nurse today. Can we let's start by you telling me your name and date of birth, please. And she tells me her name and date of birth. It matches the wristband. It also matches my order. While I'm looking at my order, I'm checking my allergies. I see that she's allergic to betadine and codeine, which is not going to be an issue for these medications that I'm giving. Now, Francis, I'm here to get you going on some potassium chloride that the doctor ordered. We're going to run that through your pick. I also heard that you're in quite a bit of pain right now, so I see from your charts that the morphine works pretty well for you. We're going to give you a dose of that. It's been long enough since your previous dose, so we can give you another 2 milligrams of morphine. Do you have any questions about getting that potassium in your line? And she says no. And I also asked, do you have any questions about the morphine? And she says no, she takes it frequently for her pain that is chronic. So just to recap with the morphine, it might make you a little drowsy. And if you do have any strange side effects from that, feel free to let me know. I'll be keeping a close eye on you regardless. And then with that potassium, sometimes that can be a little caustic. Shouldn't be an issue with your pick. But if you have any burning sensations or upset stomach or anything while you're getting that potassium, please also let me know about that, okay? And she says yes. Okay, so patient understands what we're doing and agrees to cooperate with both medication administrations. I've looked at my Betty book. My normal saline is compatible with both the morphine and with the potassium chloride, and conveniently the potassium chloride and the morphine are also compatible. However, I will be administering those in separate lumens anyway. I also know that looking at my potassium, which is what I'm going to administer first, doctor's order is 10 milliequivalents in 100 ml IV piggyback. I do have exactly that in a bag, and looking at the Betty book, I see that the 10 milliequivalents per hour is the recommended rate. So I'll do a 100 ml per hour, which will be the 10 milliequivalents for my rate for my piggyback. And then for my morphine, I've already looked at that for the IV push in the Betty book. It can be diluted, but it doesn't need to be, so I'm not going to dilute it. And I will push it over 4 to 5 minutes as recommended by the Betty book. Of course, with the flush before and after the push. So I've done let's go ahead and clean my stats potassium. And I'm looking at my MAR, and I'm going to do my 5 checks. So I have Frances Christensen, as we've already confirmed. She is receiving potassium chloride, 10 milliequivalents in 100 ml via IV piggyback stat. Again, I have Frances Christensen, and she is receiving her potassium chloride stat, 10 milliequivalents in 100 milligram via IV piggyback. And again, Frances Christensen, she's receiving the potassium chloride 10 milliequivalents in 100 ml via IV piggyback stat. And again, to clarify, that 100 ml will be run over 1 hour according to the recommended rate in Betty, which is my math calculation. Last thing I'm going to do with my checks is I've looked in my bag. I don't see anything floating, any weird inconsistencies, anything of that sort. And my expiration date is good. It doesn't expire until 2035. So this is a usable bag of potassium chloride. So I've done my 5 checks 3 times, and now I can go ahead and get her secondary set up. Are you able to see this? Yeah. Okay. Alright. So I'm making sure that this is remaining sterile. I would pop the cap off of this as well if it was still on there. Spike my bag. My roller clamp is closed. I'm going to prime. And then I will very carefully, or pinch, now I'm going to very carefully prime. And not lose any meds. I dribbled just a little bit, but. Okay. Now this is still capped, so I'm just going to set it here for now. I'm going to pause this. Just temporarily get my alcohol swab. My highest Y port. I'm going to cleanse it according to facility protocol. My facility says 15 seconds, so we'll say that that's 15 seconds. I'm letting it dry, not touching it. It's dry now, so I can connect my secondary. I'll lower this guy. Okay, now I'm going to do the channel, secondary, and I'm going to do basic secondary because potassium is not in our Alaris pump. As previously discussed, that 10 milliequivalents in 100 ml, so I can only run it at 100 per hour. And then I'm going to infuse all 100. At that point, it will switch over to my normal saline again. So I'm watching, and I do see that my potassium is dripping. I've counted 5 or 6 drips now, so I know that that is running. And everything was good there. So my potassium is now infusing as per doctor's order. I would clean up my stuff here and make sure that I'm not making a mess of the patient's room. All right. If it didn't already, if I had to set this bag up, I would have also checked my site prior to starting any sort of fluids. And since it was already running, I didn't, but I'm looking now and I see that there's no redness, no inflammation, no warmth, and the patient hasn't made any complaints about that IV site. But I would always be keeping an eye to make sure that that it still looked like a good viable line. So now that I have that potassium running, I'm going to move on and get Frances more comfortable and deal with that pain. So I want to administer my morphine IV push, and I've done my math. I have morphine 10 milligram in 1 ml. My doctor ordered 2 milligram IV push every hour as needed. So after doing my math, I've calculated out that I'm going to give 0.2 ml to equal out to that 2 milligram. Okay. So I have my bag. I would probably wash my hands and glove here, just to be cautious. I don't want to infect it at all. Sanitizing, again, facility protocol, 15 seconds. And we'll say that that's the full 15. Now I'm going to let it dry. Got my VAD on there. And again, 0.2 ml. I'm going to draw back. Make sure as many air bubbles are out as I can. Getting all those bubbles out. Okay, so I am at 0.2 for my morphine. All right, now that I am dose accurate here, I'm going to do my 5 checks. Again, even though I did just check, I would be making sure that I am with the right patient. I haven't left the room, so it's not an issue. But if I were to leave the room, I do have my label stating that I have morphine 0.2 ml, which is 2 milligrams, that I would keep on my tube if I were to be pulled away at all. I have that label ready if I needed it. I'll just pop it on there now. Also, if I were to have to leave and come back, I would start over with checking my patient's ID and birth date against my chart, her word, her wristband. And I do know that I still have Frances. I do IMSA in Frances's chart. And I have already talked to her about her allergies, but if I hadn't, I would double check and ask her, Frances, do you have any allergies? She would tell me the betadine encoding, which I confirmed with the chart, and we're okay with that and giving the morphine. My morphine, again, I did check the bottle, no sediment, nothing weird going on there. Expiration date is 12 of 2030, so we're okay there. Now I'm going to do my five checks 3 times. So I have Frances Christensen, and I am giving her morphine IV push every 1 hour as needed. It's been over an hour since her previous dose, and it's 2 milligram ordered. I have the 10 milligram per 1 ml, which equals out to 0.2 ml. Again, it's Frances Christensen, and we have our morphine IV push. I'm giving that every 1 hour as needed. More than an hour has passed since her last dose, and we are giving 2 milligram. So at 10 milligram per 1 ml, that equals out to 0.2 ml. And last check, I do have Frances Christensen, and we are giving her morphine IV push every 1 hour as needed, and it's been more than an hour. since that last dose, and we are giving 2 milligram. From a bottle of 10 milligram per 1 ml comes out to 0.2 ml, which I also have on my label. Okay, so I am comfortable after those 3 checks that I am giving the right medication to the right person, right dose, right time, right route. I'm going to come over with another alcohol swab, and I can remove my VAD. And we're going to use this other lumen. I believe I mentioned previously the morphine is compatible with the normal saline and the potassium, but we're going to use this other lumen since it's available. 15 seconds per company protocol, and I am letting it dry. Before I do that though, I am going to flush, propping that so it's not touching. Making sure beforehand I did make sure all the air bubbles were out of all 3, but I'm looking just to be certain this time, and we are good. I have sanitized this with the swab so I can do my first flush. And as previously stated, if this wasn't already in use, I would also be doing a site assessment. But I did that upon admission just a couple of minutes ago. Okay, so that one's good. I can throw this in the garbage. I would re-clean. 15 seconds, let it dry. Now I can give my morphine. And it's dry. I'm going to connect. Okay. Oops. Just kidding. What the heck? That didn't happen. Okay. I don't know why that's being ornery. Now, Betty Book said over 4 to 5 minutes for the morphine. So it is a tiny little syringe, so I'm going to be super cautious that I'm not pushing too fast. But I would keep track, and I would be giving my morphine over 4 to 5 minutes. This is where some people may dilute it because it makes it a little bit easier to pace it over that range of time. But I'm just going to move it ever so slightly here and there so that I'm not administering too quickly. Okay, and we're going to say, for sake of time, that this is 3 minutes, 2 minutes, 1 minute, and now it's been 5 minutes. So I've administered my morphine over a total of 5 minutes. I am now assessing Frances for any side effects for the morphine, making sure that we're not having any serious respiratory depression, no nausea, that we aren't having any issues with consciousness or anything of that sort. But Frances does get morphine regularly, so it's not anything new to her, so she's not having any surprise side effects. One more swab here. Gonna bring these guys over. Again, for 15 seconds. That's my 15 seconds, so I'm gonna let it dry. Another bubble sneaked in there, so I'm not gonna do it over my patient. I'm gonna get that last bubble out. Whoop. And on there. Now again, I'm gonna do at least 5 ml at the same rate as I did the morphine, which is at 4 to 5 minutes. So very slowly, because I don't want to bolus that last bit of morphine for Frances. Okay, so we'll say 5 minutes have passed. Okay, we're here, 5 minutes have passed, and I can just finish out this guy. I can, since it's a pick, I can pulse already, and I'm pulsing just to make sure that we don't end up with any sediment or anything in that pick. And one more flush that I'll pulse all the way through. 15 seconds, letting it dry. No air bubbles. Also, none of my saline flushes were expired either. Okay, and pulsing. This is something that you do with the pick specifically, because there is just so much catheter. Okay. I'm going to clean up my mess. I'd put the appropriate things in the garbage. If there was anything with blood stained, I'd deal with that and the biohazard, but we're good there. So, let's see. So this stuff is now in the garbage. And then I can move on to changing my dressing because it is due to be changed. I'm just going to kind of clear my table. I would put this in a different space in the room, maybe over on a different countertop, so that I could use this table for my sterile procedure of dressing change. So I'm going to get that stuff out. All right. Now for the last skill, we're going to do our central line dressing change. This is usually something that the facility has ordered to do it so many days, or where I work, they do it every Monday, is central line dressing change, or as needed, which is what's listed in this order. So if the dressing were to become soiled or peel back too much to be trustworthy to be holding the pick in place. So I've noticed that according to my facility policies, that the pick is supposed to be changed every day on this day. So I'm going to get it changed for Francis now that I've finished administering those necessary medications. So I've checked my chart and checked my order, and I am sure that it is appropriate to change this dressing for Francis today. I've also checked over her allergies, and it is still that betadine and codeine. I'm not using betadine, and I am not concerned about the codeine for the dressing change. If she did have an allergy to one of the cleansing solutions, I would find an alternate antiseptic for her skin. So I can bring my table into the room. I just want to kind of switch sides. Yep. A little further here. All right, Francis, the last thing we want to work on right now is getting your central line dressing changed. It's peeling up a little bit here, so I'm going to get a fresh one on here for you. It is a sterile procedure, so we're going to ask that you wear a mask and hold still for me while I'm doing it so I can keep this space sterile. Do you understand what I mean by that? And she says, yes, that's okay. And she complies to wearing the mask, which is great. If she wasn't going to wear the mask, I would have to ask her to look away from the site, so at least she's not breathing towards my sterile space. A lifetime modification here is if it was a child or maybe somebody with any sort of dementia or cognitive impairments, I'd have somebody else in here helping me to make sure that they were distracted, that they could hold still, and that to just help me keep control of the situation, because it does need to stay sterile while I'm cleaning, to avoid any sort of a risk of a infection, which is a common hospital-acquired infection. But she has agreed, she understands, so we can move forward. I'm going to wash my hands, and I can grab my kit. I don't really want to open it. Well, wash my hands, and I'm going to open up my sterile kit away from me. I want that mask, but I can't. And I will wash my hands again and put on, well, and I'll grab out my sterile gloves first and set them aside. And then I'm going to just kind of come to the side here, making sure I don't get into the rest of my kit. And I'm just going to grab the strap of her mask. And then I will put this on Frances. Okay? And we're going to keep that over your nose and your chin. Okay, now my sterile field is open, so I'm going to be extra careful not to contaminate that while I move forward here. So I don't want to turn my back to it at any point. So my next move is to remove this dressing. So I will wash my hands again. I'm already wearing a mask upon entering the room and the shield, but if I didn't already have the mask on, I would wash my hands, put on my mask, and wash my hands again, because I also have to be masked for this procedure. So I'm going to wash my hands, and I'm going to put on my clean gloves, and we're now going to remove this old dressing. And I'm going to roll it in from the outside edges towards the insertion site. Still making sure I'm not ever actually putting my back to my sterile field. Okay. So I do have it mostly off. I'm going to stop here and just grab, I'll have that for later. I'm going to measure 6 inches up the arm from insertion, and then I'm going to measure in centimeters, and I'm going to compare that against the baseline in the chart. I already looked at the chart, and this is darn near the same. If it was more than a 1/2 inch variance, that would alert me to potential phlebitis, infiltration, or other issues with the viability of the pick. But everything is good there, so I'm not gonna worry about that. My other thing, I just stopped here because I want to measure from the hub to insertion and compare that as well against my chart. And I can touch it here because it is still covered by the bandaging. And it is the same as what I saw on my chart for the length of catheter exposed from hub to insertion. So I can be done with my ruler. I would probably wash hands again at this point, and put on another pair of gloves, just because I was messing around with my tape measure. Now I am peeling up so that I don't accidentally pull out my line. Okay, that's staying. Gravity's not fighting me like that. Now I can do my sterile change. So I'm going to remove my gloves. I'll wash my hands and put on my sterile gloves. I'm going to open them up. Being careful that I'm only touching the inside, not the sterile part of the glove. Okay. Not crossing that sterile field that I had to open previously. Now I've got them mostly on. Both hands are sterile, so I can straighten them out a little bit. Okay, so I'm now sterile. Hands can't go below my waist, and neither can my sterile space here. I've assessed visually that that there's no redness, no swelling, and after cleansing everything, I'm going to touch and check for warmth and tenderness. So I'm going to go ahead and just grab my tweezers first, and my alcohol swab, which is pre-soaked in the alcohol, and I'm just going to hold here, and I would clean up any sort of drainage. From the site, like so. Next, I would grab my chlorhexidine and I'd click it. I would wait till that dried, the alcohol, and I would also have scrubbed according to the facility protocol. I've clicked it, so now I'm going to scrub. This is my actual antiseptic, and kind of going in a circular motion around it. Definitely inward, outward. I wouldn't want to bring germs towards it. Timing again is according to my facility's protocol, at least 30 seconds. And I am scrubbing. I don't want to rip at the patient's skin, but I do want to make sure that I am getting it good and cleansed. Okay, so we're going to say that that is the 30 seconds. I'm now letting it dry. And I can set this guy down. And I'll get my skin prep. I will open it up. And my antiseptic has dried. I'm just going to go in a nice square around. I'll get underneath here carefully so that I'm not moving and pulling the picket off. Okay, so we are now prepped with the skin prep. I could take my gloves off at this time, but I'm not. I'm just going to leave them on. Last thing I want to do, I'm going to make sure that my tegaderm stays sterile. Touching only the edges. I do have gauze and tape in there if I needed it, but I don't feel like that those are necessary at this time because it didn't need propped. So, keeping this sterile. I'm going to put this on in such a way that you can still see the site clearly. For future assessments. trying to get on there as flat as I can, making sure there aren't any bubbles. And again, I had used the no-touch technique to maintain sterility. Pull this off now, making sure that the edges are nice and stuck. I would use my pen. I'm done here, so I don't have to worry about that. I'll set that down. Wash my hands. And because we are at school right now, I'm going to get another pair of gloves on right away. I would grab a pen and I would initial and date my Tegaderm wrapper to note when it was last changed. And I'm going to put that right at the base just because with clothing going on and off and whatnot, it's most likely that that's where it's going to pull up on the patient, so that just kind of reinforces it there. And as I had previously mentioned, there's no warmth here, there's no tenderness. Frances is comfortable with all of that. So I can clean up here and put everything in the garbage. With a central line, I would, of course, always be assessing whether or not it was necessary for the patient to have a central line. In Frances's case, she is going through chemotherapy, which is why she has that PIC, is for regular access for her chemo. So it is appropriate to have that PIC. The reason we're assessing that is because it can be a very serious infection, because it does go right into that big vein. So we want to make sure that if it's not necessary, we don't have it in. Also, somebody was wise to think that she should have one because it's advantageous for her to have that PIC in with the chemotherapy. As I mentioned before, lifespan modification for the PIC would be getting assistance if needed to maintain sterility. Oh, I'm sorry, Frances, let's get that mask out of your way. And she took it off, handed it to me, I put it in the garbage. I'm going to wash my hands again. Lifespan consideration for the potassium. The biggest one is you cannot give potassium push. It does need to be given slowly. For an adult, it's that 10 milliequivalents over an hour. Pediatrics would be much slower than that. You would be monitoring with the potassium for any sort of reaction, pain, inflammation, burning, or side effects to the potassium because it is strong. We would probably also be doing cardiac monitoring with giving potassium. And then the morphine, as I previously mentioned, we're monitoring for signs of side effects or adverse reactions to the morphine. Lifetime considerations, elderly patient, you're going to use something like morphine very cautiously because you don't want to over sedate them. You may start with a lighter weight, so to speak, painkiller before you go to the morphine. But Frances's scenario, she's in a situation where she is having chronic pain, so she's been using that morphine for that pain for some time. I would, of course, ensure the client's safety. I'd have the side rails up, make sure Frances has her call light. I would make sure she was comfortable, if she needed a warm blanket, and if you drink anything like that. Is there anything else I need here? I would document, upon leaving the room, I would document the IV piggyback potassium, and I would document that it is secondary, that it is the rate administered when I started it, how it was tolerated. I would also document the morphine that I administered, the 2 milligrams, which was 0.2 ml, I would chart that I documented it in the second lumen, which was available in the pick. I would document how it was tolerated. I would come back in about a half an hour and assess her for pain and see that it was in fact helping with that 9 out of 10 pain. And I would document my central line dressing change as well. Notating, I would do Rita. When I was changing it, I was looking for any redness, any ecchymosis, any drainage. Not much for approximation there. I would also have looked at my dressing when I pulled it off, making sure that there was no drainage on there. If there was, I'd be checking color, order, consistency, and amount. I would have documented if there were any issues, but I did not see any. I document where my new length from insertion to hub is, as well as my circumference of the arm, so that next time it was changed, we could compare against those numbers again. And I believe that is everything that I would have documented, and that is my cumulative skills scenario for Frances.